Well, thank you very much for inviting me. I see some familiar faces in the room from previous meetings and various things, patients, etc. So it is a real honor to be here. A large part of my life and my training is dedicated to helping prostate cancer patients and their families. And it is something that I am very passionate about. It's something that I feel we have a lot of work to do until we can actually find a cure or cure more men or cure more men with less complications. And so this is something that it's hard to shut me up about sometimes. But I also want to take the opportunity before I get into the talk that I was planning on giving to say that the work that you guys do as a group in supporting patients with this diagnosis is tremendous. I often will sit down, I may have sat down with some of you guys and said, you know, I don't envy your position in terms of trying to decide what the best thing to do is for you, trying to decide on between various treatments where there's no real right or wrong answer. These issues are and these questions are very challenging to answer, and they're very individualized. And I couldn't help it over here just a few minutes ago, somebody saying, you know, there's information and things and support that you guys can provide that doctors can't provide. And I couldn't agree more with that, because I haven't had the surgery. I've performed a lot of the surgeries and see a lot of patients with it, but it's not the same as going through it yourself or making these decisions yourself. So the work you guys do in supporting patients with new diagnosis or new changes in their health status is really tremendous. And I want to applaud you on behalf of all of us who dedicate a lot of our lives to trying to help you. So thank you for that. I also want to make this as interactive as you want it to be. Feel free to interrupt me at any time. If you have questions, I'd welcome interruptions or questions about it. We can also ask questions at the end. However you want to do this is fine by me. Also, if you have questions unrelated to what I'm going to talk about, please feel free. So I put this picture up here because this was very early on in the robotic surgery program at the Ottawa Hospital. And this was in our hospital newsletter that goes out to all the hospital staff. And it may seem like quite a large group, but this is, as you'll see in a few slides later, a tiny group of our robotic surgery program. And what I hope it conveys is that this is not one person or two people. This is a team. And right from when I arrived from the United States, my first mandate or my first request was that this be a major team approach, because the more that we could work as a team and learn from each other and work in a cohesive group, just like anything else you do in life, the more chance you're going to have at success. The other thing was, the last time I was here, I actually found this on, I think it's your website or somewhere. So it was October 20th, 2011, the last time I gave a talk here. The first robotic prostatectomy I performed was October 31st, 2011. So it was about 11 days before the first operation that we did. And like was said earlier, you know, there was a lot of mystery around what robotic surgery was, and I'll explain a little bit again to those who are new to it. But I also want to really show what has happened since that time, because I'm very, very proud of what we've been able to accomplish, and I want to be able to share some of that with you. So these are at least some of the members of the team now. So there's that picture early on with maybe 10, 15 people. I'm not sure what the last count is. Huge number of nurses that are specialized, trained in this procedure. We have had tremendous support from Jack Kitts, who's the CEO of our hospital, right down through to Ron Gerritsen, who was our former chief of urology, and now it's Stuart Oak. Anesthesia has been on board, as I'm going to show you some data on later, showing how anesthesia has really bought into this approach of having teamwork. From the people who clean the instruments, to clean the rooms, to perform the surgeries. As you can see here, there's a large number of surgeons that we've been able to train to perform this procedure. So there's different ways you can do it. In many other cities, in fact, there would be one or two people that would be the only people to use the machine, and nobody else is kind of allowed. That's still the way it is in many cities. But you know, it's sort of like you give a man to fish, you can feed so many people, you teach him to fish, you feed many more of that idea. Well, that is really the approach we've had. So we have tried to train and mentor as many people as possible so that this type of procedure, this technology was available to more people, because you know, I can only operate a certain number of days a year, and that's not enough for what patients need in our region. So I'm very proud of the fact that we have been able to have so many people operating at such a high quality level pretty quickly, I would say. So why are we talking about this? Well, this was a major priority for our region, not only our hospital. You'll see a little bit later, we were fairly far behind when I arrived here. When you compare us to similar sized cities like Edmonton, Calgary, London, Ontario, Montreal, Toronto, which are a bit bigger, many of these places had several of these technologies available to patients, and we were, I would say, behind. One of the reasons is that many of these things are driven by donations. And another reason why I think it's important to present this to you is that many of you people have done lots of fundraising work to get this technology in Ottawa. There have been several people you know, who really spearheaded the initiation of this project, but the Ottawa Regional Cancer Foundation, Prostate Cancer Canada Group, the Ottawa Hospital Foundation, obviously, and several individuals really pushed this forward and tried to really fundraise. This was a major financial donation, and we've been, you know, really grateful, and our patients are certainly really grateful that they can get this treatment within Ottawa without having to travel very far, and at no cost to them, because it is covered through patient donations. So I say we should all take pride in this program, because this is something that is community-based, entirely community-based, in fact. And so it's important that the community and people like you understand what's been happening and how patients have benefited. So the other thing is that with any new program, especially something that's as, I would say, maybe flashy as robotic surgery, there's also a lot of scrutiny. And there were people who didn't understand it, maybe were concerned about various things, certainly concerned about the fact that it's an expensive operation to do. And so we were under the microscope in a majorly big way. And for, in fact, a couple of years, we went about our business doing things as quietly and as well as possible, collected information. But we're really at a stage now where we don't want to kind of keep things in secret. We actually want to share things a bit more and take some pride in what we've done. And I've given a similar talk like this to our operating room staff for the same reasons. Many people weren't allowed to come in and see what was going on. Now we encourage people, come in and see it, because it's a pretty great system that we have going. So what I'd like to do today, and this is by no means all-inclusive, I'm happy to take as many questions as you want. There's often a lot of misconceptions about what it actually is. I'd like to talk, as I said, about what we've been able to accomplish so far. I also want to talk about what I foresee in the future for further helping our patients, and of course answer questions. So this robotic surgery platform was approved in 2001. So again, it was 10 years later before we got one in Ottawa. This is really all it is. While it's called a robotic system, it's not really robotic, because robotic implies some form of automation, like your Roomba vacuum cleaner or something like that goes around and does its own thing. This actually doesn't do anything on its own, but it is really an incredible instrument, and it allows us to do things that we wouldn't otherwise be able to do with our eyes and hands in the patient. So this is the surgeon console. There's three parts. This is the surgeon console. That's where I sit, or the surgeon sits. We have two of these actually, and we have another one almost like a driver's ed car. We have another system there, and that's for training fellows other surgeons. So when I was mentoring the other surgeons to perform this operation, I would sit at one of these, the other surgeon would sit at the other one, and we could go back and forth during the operation, take control back and forth to show things. While the other surgeon operates or while I'm operating, you can use these joysticks to put little arrows on the screen and things like that. It's really an incredible teaching tool, and we've been able to train many, fellows who have gone to other places, who are going to stay in Ottawa on how to do it using this system. It allows us to do this very safely for the patient, because that's always a concern. How do you train new surgeons and do it in that you still have excellence in surgical care? This is the area, it kind of looks like an octopus, and this is the area where the instruments are inserted. So there's 4 arms on the robot that we have. This middle one that a nurse is holding holds the camera, and these 3 have instruments that go on the inside. And at the very tip of those instruments, tiny, tiny, tiny instruments, is what actually is used to do the operation. So a pretty big machine that has a bunch of working parts, but what's actually moving is kind of what's very, very small down at the end here. The third part is the computer, or the sort of interface. So that's what takes what I do here, goes to this computer, and then translate it over here. So if I move my hand 3 centimeters on this joystick, it gets scaled 3 to 1, and it only moves 1 centimeter inside the patient. So it allows you to make very, very precise, small movements. The other thing that this provides is it gives us an extremely nice high-definition 3D image of what's going on inside, 10 times magnified from what you would see with the naked eye. So you can see blood vessels, tissues that we never were able to appreciate when we did these procedures predominantly in the open fashion. So that information gets sent to this computer, gets sent back to the camera here, and it's all obviously in real time, so you can see and move things as you go.
Doctor?
Yes?
One question that I heard people talk about. We talk about robotic, we talk about remote robotic surgery. So my question to you is, the console that you're sitting at, is that wired to the arms, or is it wireless, remote to the arms?
Yeah, good question. So for those who didn't hear it, the question was, you hear about remote surgery, and is this plugged in through a cable, or is it wireless remote? What we have is cable driven. So there's cables that go to the console, and there's cables that go from the computer console to the machine itself. Now, the reason why robotic surgery was developed initially was by the US military. And the rationale was, could they develop a system that would allow a surgeon to do surgery in the field while being at base camp or something like that, a more controlled environment. And while that's still kind of in the process, there's a lot of things that make that a tough reality. But what they realized is that this would allow a surgeon to do many things, even if they were just 10 feet away. And that's really what it is. So when I'm doing the procedure, I am about 10 feet away from the patient, but I could be 10 miles or 1,000 miles. And these procedures have been done across the Atlantic, on ships and that sort of thing. So this type of thing is possible, but we don't currently use it very often. We don't use it in Ottawa at all for that reason. It's still sort of under investigation, but it's possible and it can be done. It's really the same idea. So in this picture, just to give you an idea, these are sort of the surgeon's hands in the joystick, and the instrument is in the same position as your hand. So if you have something, grasp something, you pinch it with your fingers, and that does the same movement inside. Except it's extremely magnified, as I say. This is about the size of a dime, the end of this instrument. So it's really hard to imagine until you see it, how scaled these things are. Because when you're looking at it on videos, it seems huge, but it's really, really tiny, tiny movements. So what does the robotic system do? There's a lot of misconceptions about it, but this is what it really does. As I said, it magnifies it. It magnifies it to a much greater degree than we could ever see with our eyes. It's better instruments. The instruments that I use to do this procedure are better than what I do for open procedures or laparoscopic procedures, no question about it. It removes surgeon tremor. I've heard that some surgeons have a tremor, but I guess that might be an advantage for some. No, but everybody has a tremor to some degree. I don't think this is actually a really big deal, to be honest. But when you are making movements, extremely tiny movements, then tremors maybe make a difference, but certainly there's none with this system. It's also, as I said, scaled movements. So I can change the scaling of the movements to move sort of far when I move at a small distance or move a very, very short distance. And for prostatectomy, which is a really highly fastidious type of operation where you have to do things quite carefully, we put it on the maximum scaling so that like I said, a 3 centimeter movement with my hand would equate to only a 1 centimeter movement inside the patient. Also, the computer interface is a big one. I already said a few things that the computer interface allows us to do. It allows us to switch back and forth between surgeon and trainee, or mentor surgeon and mentee surgeon, which is really an incredible asset. It allows us to draw directly on the screen and the surgeon can see it. So if a resident or a medical student has a question, they can say, put a line around something and say, what's this? And we can tell them what it is. It's really, amazing technology. There's also a lot of other things we can do. If we have CT scan images, we can actually interface that CT scan with the image that we're looking at. So we can look at anything that you can put on a computer, you could put in your sort of console cockpit that you're seeing inside, so you can see the surgery field, the other things if you want to. And I think where that's really going to go in the future is you're going to have maybe an MRI with where the tumor is in the prostate, and that can be superimposed on the prostate that you're actually seeing inside the patient. We are working on some things where you'd put an immunofluorescent dye in that might stain the outside of the prostate. So if you're doing the surgery and you cut at one point inside the prostate, and sometimes it's difficult to tell what's neurovascular bundle and what's prostate. It might light, it would glow green if you ever cut into an area where the prostate was. I mean, these are the things that are happening in the future, and these are things that would only be possible using a system like this. What it doesn't do is do the surgery automatically, and that's sometimes what people say. Some people, not so much anymore, but I had heard in the past, I want you to do the surgery. I don't want a robot doing the surgery. And it is not a robot doing the surgery. It doesn't do anything on its own. So any good things that happen are the surgeon's fault, and any bad things that happen are also the surgeon's fault. We can't blame anything else. So how do patients benefit? This is the main reason we do it. Who cares if you can see better, if you have less tremor or whatever, if it doesn't end up meaning something better for patients? Because as I said, the robotic surgery platform is more expensive. It's about $2,000 more per operation. And if you multiply that by the number of operations that we do, that's a lot of money. But there are major benefits to patients, and I'm going to show you some of those. Less blood loss is, without a doubt, no question, a major difference. Shorter time in hospital, I'll show you some data on that. Faster recovery and faster time to getting back to the things you love to do in life. Improved quality of life, which I'll talk to you about, and improved overall patient experience, which we are always striving to achieve. So this is a little bit of an idea. I kind of brought it up earlier. So these are each progressive year since the robot was initiated, and these are the locations where the robot exists. As you can see, there's lots of dots around London, around Toronto, Montreal, Edmonton, Vancouver. Here's Ottawa with one orange one, and we have this thing going pretty well every day. And I'll show you some of the numbers of procedures we do. So we have this going 5 days a week, every week of the year. And that's why we're able to achieve what we do. We probably need more. We need more access so that we can help more patients or do more surgeries. I would love to use this to help patients with kidney cancer and bladder cancer and other things. But right now, we have so many patients with prostate cancer and uterine cancer and head and neck cancer. We just don't have any more time to gain access to it. But we will, and I think that's something that will happen. Hopefully, if the price comes down on these, then we'll be able to do it. It's not a matter of if, it's completely a matter of when. And part of that has to do with just financial realities that we're dealing with. There's a couple of questions.
Yeah, I was wondering if there's any difference in the amount of time that the patient is under the knife.
That varies from surgeon to surgeon. So the surgery times in general vary. My experience, my procedures are faster when done robotically than done open. But I've done a lot of these robotic procedures. Some people, it's longer doing it robotic than open. We have gone up in the amount of cases we can do, and I'll show you some of the reasons why that is. So at our center in Ottawa, it's actually less time for the patient to be under anesthetic. I can't say that universally across the country and across all surgeons, because I think there's some unique things that we've done to make it that way. You would think it would be longer because there's the whole process of bringing the robot in, docking it, and all that other stuff. But what I have certainly found is when you can see things better, you have less blood loss, you can see all the tissues, you're not spending a lot of time sort of sewing up tiny little blood vessels trying to, prevent blood loss from the patient. You can actually progress through every case, even really challenging cases that would historically been thought to be not possible. We're able to do them now fairly quickly and safely, most importantly. There's another question.
So your system is not used by other areas like neurology or do they not want this kind of system as well?
Yeah, they do.
And they don't have it?
Correct. We have three, I'll show you, I showed it earlier, so we have three patient populations that use it. So prostate cancer, it's used primarily for prostate cancer, but also many women with uterine cancer. So we were the two sort of programs or the two groups of patients that we felt had the most to benefit. So we started with them. About a year and a half ago, we expanded to base of the tongue tumors. The reason we did that is that it sounds horrendous, but if someone develops a tumor at the base of their tongue, there's really no easy way to get at it. So the only way to do it is to take the jaw and completely split it in half, like this, bring this down, bring the tongue down, and remove the tumor that way. The way we currently do it, we can do it all through the mouth using robotic instruments without having to do anything. So, you can just imagine what that means to patients. So now there are a very small number of patients, so there was big time benefit and a very small number that would need to be done per year. So that was one of our major priority areas that we went to. Lots of other surgical groups have shown interest, and rightfully so, for cardiac surgery, colon surgery, liver surgery, lung surgery, and I think all could benefit. The issues are resources, gaining access to it, and also training, because it is a skill set different than what most people would traditionally have to use it. So part of that has to be recruitment of individuals that are experienced doing it. But I think there's many areas that stand to benefit. Like I said, it's more the financial realities that are restricting us. We have a steering group made up of numerous people, and if a surgeon really feels strongly about something, especially if it's in a small number of patients, we encourage that, and we want to include those patients because we want to help, especially like in the sort of neck, tongue-based tumors, where we really felt we could help maybe a small number of patients, but in those small numbers make a huge difference.
Do you do a surgery at night? Is there certain hours?
Yeah, no, we don't currently. So all of our surgeries are done in the daytime for elective surgeries. So it's just the way that the hospital's set up. At nighttime, now surgeries do happen through the evening and night, but they're reserved for emergency surgeries. And we have so many emergency cases that we operate most nights, but they're usually not, thankfully. Prostate cancer is not an emergent thing. It's more of an elective thing that we can schedule out, which is better for everybody. Any other questions? Yes?
Since you introduced it about 3 years ago, 4 years ago?
Yep.
Yeah. Has the technology for that system advanced?
Yeah,
they had new iterations of this and said, New software updates and so on.
There's one. It's not available in Canada yet. It's a little bit, I would say there's an incremental benefit. There's not enough of a benefit to me that it would actually impact prostate cancer surgery. I think there's things about it that would allow to better colon surgery, I think, or surgeries where we need to kind of move all through the abdomen. So young men who have testicular cancer, for example, sometimes have to do big operations, quite big operations on those young guys, often in their teenage years or early 20s. And if we had something like that, we might be able to help those people. But right now, I think the technology we have is actually really, really good. So I'm not like envying my old colleagues in the US who have some of the newer editions. I don't think it adds a lot. So how is TOH, or how has the Ottawa Hospital done this differently? I alluded to it a little bit more. From day one, team approach and making sure that people were adequately trained, up to speed. So we went through a lot of planning to do this. We also had, and we still have, a pretty rigorous mentorship pathway. So when other surgeons, and we now, I said, have like 15 or 16 surgeons, there was a very rigorous process of how those patients learned to do the surgery, which included a lot of time operating with me. And so they would go to, do courses in the United States. They have to do online courses. We have a surgical simulator, which is really good. It's almost like the real thing. You sit down at the console and you have to be able to show proficiency at numerous things before you actually even start looking at a patient. And these are all things that we don't actually have for regular surgery. So by the time the surgeon sits down to actually do anything to a patient, they're quite expert at actually how to move the thing, and what they're concentrating on is the anatomy. Then they would do a number of cases with me, and then as those surgeons became very competent, then they became mentors for others, and it sort of was a snowball effect, I guess, and that's what allowed us to train so many people in such a short time. Now we still have people going through the mentorship training pathway, and it continues. And we also have continual relationships where if there's a very challenging situation for one case or another, two main surgeons may do the operation together, because two opinions are better than one. And because of that, I think is a major reason why we've been able to achieve the outcomes that we have, and I'll show you some of that later. We've also standardized. There was a really interesting article written, I think it was in the New Yorker or New York Times or something like that, by a surgeon who compared hospitals to the Cheesecake Factory, which is a restaurant in the United States. And he basically kind of went on and on saying the reason why you can go to, Moxie's or one of these kind of chain restaurants that do a pretty good job is that everything is standardized. There's like 2 shakes of salt in this, and everything is standardized, and allows for a certain level of proficiency or quality. And he makes the analogy that you can do a lot of those same things. That's done in business, that's done in all kinds of engineering firms. Why can't that be done in hospitals? And we have basically done that as much as we can to the things around the surgery. So in how the instruments are set up, how we clean the room between procedures, how the patients are treated under anesthetic, which, believe it or not, can have quite a large variety. So we kind of found out what we thought was the best thing for patients, and we standardized it. So it doesn't matter who the anesthesiologist is that you see that day, they're going to get the same anesthetic, which will allow them to wake up with less pain, less nausea, go home very quickly, usually within 24 hours or so. And so we've been able to sort of standardize this. Any of you people who have had surgery probably know there's a pathway. You get a booklet. This is what to expect before surgery. This is what to expect the day of surgery. This is what's going to happen the day after surgery. And by following these things, we can uniformly ensure at least a certain level of quality of care. We obviously want to go beyond that, but that ensures at least that quality. And what we've seen, we're the only group in the hospital for any surgery that does this. And we've been so successful, it's now been replicated in lung surgery, and the whole OR and hospital is very, very interested because they're saying, what did you guys do to achieve what you've done that hasn't been achieved in any other field of surgery in Ottawa? So if we look, and we've kept track, we've kept very close track, so we have data to help us find out what we're doing. And these were the first 100, I have the first 105 or 106 cases or so. And what we saw was the average time for the anesthetic to take place before the surgery was on average about 20-some minutes, 25 minutes or so. And we were able to reduce that time, so from the time the patient enters the room to being asleep and ready for surgery, it was, after 100 cases, down to about 12 minutes. I can tell you now it's under 10 minutes almost every single time. So a huge savings, and you may say, well, who really cares? I mean, take as much time as you need to put you to sleep. But what we have to understand is that the less time you have to do each step, the more time you have in the day to do surgeries for patients. So if all of these individual steps take a long time, then you can't treat as many people within the day because the OR day is sort of a set time. Nurses come and go for set hours. So here's surgeon time. So when we look at, and this is many surgeons, right? We saw a couple of things with our first 100 cases. The amount of variability changed quite a bit. So there was, some of these were probably, cases that were very fast, but some took a lot longer. So there was a lot of variability, but as time went on, this became smaller and smaller. And I can tell you as this has gone on, this variability is very, very small now, and it's continued to decline to, most of the procedures are under 2 hours. Started off between 3.5 and 4 hours was the surgery. Now it's under 2 hours. And that's because we've had this process of teamwork and mentorship. If we look at the total OR time, it was about 6 hours. So we start our operations at 8 o'clock in the morning, and we are supposed to be done, ideally, at 3:30. So if you take 6 hours, you can't perform 2 of these operations in a day. We've been able to drop it so that we can comfortably operate on 2 patients a day. So our wait lists, or the amount of time that patients have had to wait, has dropped dramatically, which is great. Changeover. So the average changeover time at the Ottawa hospital, so that's the time between the last patient leaving and the next patient coming in the room, is about an hour. These are the numbers of minutes for our first 475 cases. These are the number of minutes for a changeover. On average, it's about 15 minutes. And many times it's 10 minutes or less. More than an hour different than a changeover between 2 colon surgeries, for example. Really unbelievable. And when surgeons see this, they say they don't believe it, actually. They don't believe that this is, but the reason is, it comes down to how the instruments are clean. We only sort of open what we actually need. We don't, waste time opening a bunch of things that aren't actually used for the procedure. We've streamlined basically everything we can possibly streamline to allow this to happen. So, yes?
The time frame was around 15 minutes, you said, doctor?
Now it's about 15 minutes. Yeah. So this is the first year. So we got all of the data. So these are all the hospitals that have robotic surgery. And these are the numbers of cases that they're able to do in the first year. Here is Ottawa, way above every other hospital in Canada in terms of the numbers of operations performed. There's a whole bunch of reasons for that. The main one being the teamwork approach that we've used, in my opinion. So, I said, how do patients benefit? Well, shorter time in the OR, someone mentioned time under anesthetic. These things are important. Because of that, we've been able to give patients better access, more timely access to high quality surgery. This is actually out of date because the numbers are higher, but as of about a month and a half ago, 454 prostate cancer surgeries were done, 334 uterine cancer, and 13 head and neck cancer patients. This program, again, as I said, many fewer patients, and we've only been doing them for about a year and a half or so. To put this in perspective, our projected amount of cases, all total that we were planning on doing, was about 500 within the first 5 years. So in 3 years, it's almost 1,000 operations, or will be around 1,000 operations. which I attribute completely to the team effort and teamwork approach. So all this stuff, again, who really cares? What we really care about is how patients are doing. What is the difference to patients? These are actual numbers from Surgeon A to Surgeon J. These are the numbers of cases that they've done within a year. These are the number of transfusions. So 11% of patients who have a traditional open prostatectomy will require a blood transfusion. In addition to that, many men will have significant blood loss. They may not get a blood transfusion. They may have a significant drop in their hemoglobin, which delays the recovery, less energy, those sorts of things. So far, 0 blood transfusions out of 454 prostatectomy patients. We have had 2 single unit blood transfusions in patients after surgery who had, one person had a delayed blood vessel bleed, and the other person was found to have an issue with blood clotting that wasn't diagnosed before surgery. So a dramatic difference. We would have expected at least 50 patients to have received a blood transfusion. So we don't know who those 50 patients are, but this is really very dramatic. You know, I always say this when people talk about the cost of robotic surgery. I think we're okay. But if there was a pill that dropped the risk of a blood transfusion by 10% and it cost $2,000, the government would not bat an eye about covering the costs for that if it was a pill. But because the funding envelopes are different, because it's an instrument, this is almost glossed over a little bit, but this is a major deal for patients. What about our cancer outcomes? So again, this is looking at, so these are patients with stage 2 cancer, the risks of positive margins. Again, these were in our first year. The first year of this procedure, we saw a drop in positive cancer margins for people with T2, and even a full 10% drop in people who had disease extending outside of the prostate. T4, thankfully, are very few patients that we operate on. These numbers, I can tell you, have dropped even more dramatically as time has gone on. Average hospital stay, again, this was just within the first year. The average hospital stay for open prostatectomy was almost 2.5 days, or it was 2.5 days. It's now just over 1 day. It was around 1.3 days, because some patients will stay in hospital 2 days for whatever reason, if they need it. So patients are getting out of hospital much sooner with less discomfort and getting back to their lives. Early return of quality of life. So these are in patients who have had bilateral nerve spare, which is what we hope to achieve. So these are 3-month data. So with our open prostatectomies, 38% of people weren't requiring any incontinence pads by 3 months. For robotic surgery patients, it was overall 62% were not requiring incontinence pads by 3 months. And these numbers continue. Sexual function, better sexual function outcomes, early sexual outcomes, and 3 months again. What about patient satisfaction? We did a survey because we wanted to know how we could get better. And really, with the exception of really only 1 or 2 out of the first 150 patients, these were some of the comments that I shared with our OR staff. Staff very attentive, excellent stare, professional, top-notch, superb care, and it goes on and on and on and on and on. And this was actually done by the hospital. Every patient, if you've had a procedure for anything, I believe every single patient gets a patient satisfaction survey, and that's filled out. It's independent of me or independent of the division, and then when there's an issue or a patient was not satisfied, they try and address it, and we get that information as well to try and figure out what happened. But really, what has happened almost uniformly, thankfully, has been overwhelming satisfaction with the care they've received. Again, I attribute this to a lot of people who are very dedicated in providing that experience. So nothing makes me happier than seeing this. But we are always wanting to improve. We are continually trying to get better at what we do. We're trying to make the patient experience better. Unfortunately, not every person is cured. Unfortunately, not every patient has no side effects. These are the things that we continue to strive to improve on. And we actually have a number of research studies. Some of our work is actually funded by Prostate Cancer Canada and the Movember movement. So we're really quite excited about what we're doing with that. One of our initiatives is a surgeon's scorecard. Believe it or not, surgeons, for any surgery I do, I get no feedback from the government or anything like that on how my patients do and how my patients do compared to the surgeon next door or the surgeon in Toronto or London or whatever. It seems almost incredible that that's the case, but that is the case. So what we are trying to do, or what we are doing actually, is a few surgeons, we keep track of all of these outcomes, and that's the things I'm showing you, but most people don't really know. So they may be doing a really great job or not doing a really great job for patients, and they just don't know about it. So we have the surgeon scorecard. So all the patients that are coming through will be filling out all of these things about how they're doing, and then that gets anonymously compared to other surgeons within the region, and so you get a report card and say, hey, of your surgeries that you've done, this many have been cured or have negative surgical margins, and that is in the top 10 percentile or worst 10 percentile of other surgeons within the region. I think this is going to be an incredibly powerful tool to help patients. It makes sense if you provide that feedback that surgeons are going to get better, especially if they see that they're falling in the lower half. No surgeon thinks that they're in the lower half of surgeons. I can guarantee you that. When I give these talks, I always say to a group of surgeons, everybody who's worse than average, raise your hands, and it should be half the audience. This is the type of thing that is, the cold hard facts, and I think that we all want to do the best possible job for our patients. We really do, and if we have that feedback, I think the people who are going to benefit the most are the patients. So I'm very excited about that project, and that's where we're moving in the future. Again, it's a large team, and I wish that we could have all the thousands of people literally in Ottawa who have fundraised and supported the prostate cancer program, prostate cancer surgery program, and robotic surgery program, because they all deserve the credit for this and should take pride in the results. So thank you very much for your attention, and I'm more than willing to answer questions about this or others. Yes?
You're saying that you use the equipment 5 days a week, pretty much on average. What's the maintenance like though? I mean, this stuff seems like it's fairly robust, but
it is.
So what's that like?
Yeah, so we have, so part of the contract is a regular maintenance program. So there's cables and pulleys and instruments. So they do all that fine tuning and stuff at night. So there's a regular maintenance program, and then there's also issues that arise as we go. Of the 900 patients, we've had there's all kinds of these sort of safety checks, electronic safety checks. We've had one circuit that went out that wouldn't allow us to do the surgery. So far there was one surgery that we were planning on doing that we couldn't do robotically because of that. But there is regular maintenance that's required, and it's expensive. So that's part of the thing. For the entire year, I believe it's around $100,000 to maintain it. Just to give you an idea, and that's just for the cables, pulleys, whatever. So the more procedures you do, the more cost effective it is, because the maintenance costs are exactly the same, whether you do 10 of these or what we do, which is almost 300 of these procedures per year. Yes?
And any plans to get another one?
Yeah, absolutely. We'll take it. I think we've been a victim a little bit of our own success in that there's a huge demand. We've had a big demand to do these from all across the region, obviously, and even outside of the region, because this isn't available in Kingston, it's not available across the river in Quebec, in the Maritimes it's not available. So we have been trying our best to help people in those areas who want it, but it's really straining our system because we just don't have enough. But right now I can tell you it's such challenging financial times on the provincial government and even among donors. I mean, to get this instrument and to pay for all of these cases has been a massive donation, and you know, there's only so much money, I guess, you know, to go around, and we definitely need it, we definitely want it, but that's the next phase.
Why not use the same machine 24 hours a day in 2 teams?
Yeah, absolutely. I would be happy to do it. There are major union issues with the nursing staff and things like that. It's not so simple to do it. I mean, I don't think they're insurmountable, and maybe that's what we'll end up doing.
Nurses work at night.
But not the same volume of nurses. But yeah, they do, but normally for on-call type services. The other thing too, you have to be a bit concerned about is, you know, this is a highly technical thing, and we know that performance for various tasks is a little bit worse if you're doing it at 2 o'clock in the morning. So it creates some other potential issues with doing it. I mean, there has been talk about having it work through the weekends, Saturdays and Sundays, but it's not just the amount of time, it's also the cost of each procedure. And so there are disposable costs that need to be paid for. And like I said, you know, we had sort of budgeted or planned on performing 500 cases over 5 years, about, you know, 50 of these prostate cancer patients per year, but the demand is just tremendously high, and we do, you know, we perform 150 or 160 of these procedures in our region per year, so way above. So we have to figure out ways of sort of getting our arms around it and keeping it in control while still providing the service to patients.
Recovery on the operation, I mean, you're only in a day, no blood transfusions.
Yeah.
The other efficiencies, are they factored into?
No.
Change?
Should they be? Yes.
Yes.
Like, you know, people often say, well, what about cost effectiveness? And I agree completely. But it depends on where your perspective is. So the budget for the operating rooms is from the operating room budget, and they get a large amount of money because surgery is expensive, no surprise, and they have to provide care for all types of surgery across the entire region. So for the operating room, it costs more money because they're not paying for transfusions, they're not paying for nurses on the floor out of the OR budget. That's coming from the hospital budget. So there is some more savings if you look at it from a hospital budget perspective. The further out you go from a regional cost perspective, dealing with other complications, other procedures that might be required, let's say for incontinence or erectile dysfunction, things like that. The further out you go, the more attractive it is, the more cost effective it is if you include time off, all these other things, even if you didn't even consider the patient experience, which you it gets more and more cost effective, and that's been shown. They've done studies. Actually, the government has done the study showing that it is cost effective, especially if the main robot has been paid for by donations, which it has been. But the government isn't necessarily paying for that procedure from their, you know, Toronto area. It goes down, it trickles down to various things. So it is more expensive. I mean, there's no doubt in my mind it's the way to do this for most people, and it is cost effective and can benefit many patients. The issue is it is more expensive, and so I generally just say, yeah, it's more expensive to do it. You know, that's the reality. But it also can be cost effective if you're looking at it from the right way. Now these issues that we're having may be solved soon, because the government is working toward a payment for quality and payment for procedure type thing. So currently, you know, the Ottawa hospital gets a budget of, it's like $1 or $2 billion. I think it's $1 or $2 billion. And that gets divided for providing all the services. Well, the way they're going to move is they're going to say for every patient that you provide a robotic, or not robotic, but a prostatectomy to, there's a certain amount of dollars that go along with it. And when they do it that way, then the savings in terms of transfusion and bed saved, days in the hospital, bed saved, and blood transfusions and all these other things become more important, right? And so the hospital may say, look, if you're able to provide better care and more care to more patients, it actually means that more money is coming in to provide that. And that's, I think, the way it should be, actually. So this may kind of go away or be eased off a little bit, but time will tell. Yes?
I have two questions. First of all, robotics versus the normal way of doing it. What's the numbers?
In
Ontario
Ottawa?
right now?
In Ontario?
Eastern Ontario, this region.
So this region, I think it's about 75 to 80% robotic, and about 20%.
And what are those numbers? 75?
They're going down a little bit, so it's around 220, I believe, 220 to 230 prostatectomies performed within the Champlain-Lynn. So I don't know what you mean by Eastern Ontario,
Yeah,
but
that's what I mean.
yeah, Champlain-Lynn.
Yeah.
Yeah, and those are basically the breakdowns. I don't know the exact numbers. We have those numbers. Those numbers are available, but I don't know what they exactly are.
But in that statistic, is it possible that a person didn't get robotic surgery because he wasn't a fit candidate?
Absolutely.
To do that,
Absolutely.
As opposed to, I would like it, but you can't get it done because of.
Yeah.
we're too
So one thing is important to remember, and I say this to all the patients, the most important factor, and this has been proven time and time again, is not the manner in which the prostatectomy is performed. It can be done open, it can be done robotically, it can be done straight laparoscopically without the robot. What's important is the surgeon, and the surgeon doing the procedure in the way that they do it best. So if your surgeon is best, most experienced at performing the procedure in an open manner, there is absolutely nothing wrong with that, and you can get an extremely high quality surgery, and we know that the long-term outcomes won't be any different. However, if you have a surgeon who is proficient, who is a very proficient surgeon, who learns to do it well robotically, in my opinion, they will do it better robotically, because they have better vision, better instruments, everything else. But not everybody learns it. There are lots of surgeons at, in Cornwall, at the Queensway, they don't have access to it, at the Civic Hospital, and they are doing a great job. And there's nothing wrong with that. And that can cause some anxiety. Well, I had a robot, it doesn't matter. The surgeon is the most important, a surgeon who is dedicated and experienced in doing it, who's looking out for the patient's best interest. So a lot of people have come to robotics. Part of it is because we have been very diligent about our outcomes and this approach. A lot of it is word of mouth. I almost don't operate on any patients who weren't sort of sent to me from another patient. It's incredible. So it's a big thing. Like I remember after one of the first prostatectomies that we did robotically happened to be in a member of your group who came in about 2 weeks later and started doing shoulder raises with a chair. I don't know if you guys remember that, but and it was I had 30 sort of consultations the next Monday about how to do it. So part of my job is kind of saying, okay, listen, it's still a major operation. There's still definite complications that can happen. Some people sort of come in and say they're sort of expecting this procedure like a mole removal, and it's not that. It's still a major operation, and complications can happen open, robotically, whatever. The thing that you can do as a patient, I believe, is to ask the right questions. Is the surgeon doing it the way that they are best qualified to do it? Are they experienced at doing it, or have they had adequate training at performing the procedure? And those are the things that I think, as a patient, or if you're the advocate for the patient, that you really want to maximize. There are some patients that I believe are not best treated with robotic surgery, and I will tell patients that. Sometimes I have people saying, oh, I really want it this way, and I have to say to them, listen, I don't think it's ideal for you, and these are the reasons why. I think there are some extra risks, if they've had multiple previous surgeries or colon removals and things like that. They say, look, there's those risks that you can avoid by having this done in an open manner. And so, you know, at the Ottawa Hospital, we have a number of surgeons who do these very good job open, and I'll say, look, I'm going to send you to see this person because they're going to do it open for you, and they do a lot of these that way, and they should do it for you. And it's, you know, that's one of the reasons why our outcomes are getting better and better over time, I think.
Do you ever see, for example, in your career, you're what, halfway through your career now?
I hope not. I would maybe, I don't know, fourth?
But would you see, in your view, looking into the future, like we have MRI systems set up now that you can privately go in and have an MRI. Could you ever see this happening with this? In your lifetime, not my lifetime, your lifetime.
Yeah, I think I could. I think especially as we've gone on, we've realized that a large number of people probably don't even need to stay in hospital.
Yeah.
And can sort of go home, either just stay for a period of time or go home early. I could see it happening. I could see it happen, especially as, you know, if we can have a fairly robust system to identify patients who might need to stay longer. You know, we've seen that 95% of our patients are going home the day after surgery. And whenever you have those types of discharge rates, usually what people start asking is, if they're going home if that many people are going home that early, do they really need to stay in hospital at all? Because you know, so few are having issues. We're getting close to that. And so if that happens, that's when things like surgery centers and private type centers start kind of popping up. Truthfully, I hope it doesn't happen. I would be more in favor of different acuity type hospitals. And you know, a procedure like this being in sort of a more medium acuity type hospital, because then it's more efficient and cheaper to do it in that type of a setting, where you don't need an intensive care unit, for example, and you don't need all these, you know, $40 a day parking lots and stuff like that. So I hope it more goes that way, and that, you know, if you have a fairly minor procedure, you go to a low acuity hospital that doesn't need all the fancy bells and whistles. If you have something really complex, like your bladder removal, you go to a really complex hospital that's going to be more expensive, and hopefully the efficiencies can be gained that way.
I don't know if there was a question back here or whether it's been answered or anything.
Yeah, I just wondered, you were talking about the surgeon outcomes. Is that available to patients, or is that an internal?
So it's currently not even available to surgeons. Now I know all of my outcomes because I personally, or I have a research assistant who keeps track of it. So they go through and for every single procedure I do, the outcomes are documented in a database, so I can tell a person exactly, up to the last person I treated, what their expected outcomes would be. But it's very rare to have that. In fact, I may be the only surgeon who has that full amount of data. Some data is available to surgeons, like positive margin rates have been provided by the government for a number of years, and we've been sort of tracking that through the lens, so surgeons can see their positive margin rates. But that's only, in my opinion, one piece of the puzzle, because you know, there's a bit of a balance sometimes between positive margin rates and the types of patients that you operate on, and quality of life outcomes like urinary function and sexual function and those things. So it's a sort of a balance between all those things. So if you only have one piece of information, I don't think it really gives you a great picture of what your outcomes are. And a lot of these types of data are not easily available. So not only do surgeons not have it, but they don't have it, they can't even get it because we don't have that information from patients, which we want to have. It's coming, no doubt. In the UK, some information like mortality and things, you can go and Google or whatever your surgeon's name is, and you can see their outcomes. And that's been available in the UK for a while. Pretty controversial, but I'm actually very supportive of that. I would welcome that. And why shouldn't you have access to that type of thing? Because it's only going to make everybody better. And just human nature, I think. So it's going to come, it's going to be a while, I think, before something like that is available to patients in Ontario, especially at that level of detail. But it's going to come. We already have hospital information, so you can go online look at, the Ottawa hospital's mortality rate and see it ranks, whatever, 3rd out of all the hospitals in the country, or in some other field, it's worse, and that information is available freely to patients. But individual provider information is not at this time, and it's probably going to be a while before it is.
Be very useful information,
Yeah.
but I can see why there would be a certain resistance among some stations too.
It's a sensitive, and there's a whole, and in fairness, it's a really hard thing to compare. Because, you could look at, for example, maybe kidney cancer, or let's say prostate cancer surgery, and you have one surgeon who only performs surgery after radiation, where we know the outcomes are going to be a lot worse. And then you have another surgeon, they're the same quality surgeon, but they only operate on people who are really skinny and run marathons, and and then even though the surgeons are equally qualified, do an excellent job, both of them, the one surgeon's outcomes are going to look a lot better because their patients were running marathons and stuff beforehand. So in fairness, it's a tough thing to do. My biggest thing, I think, is this, as a starting point, I don't think anybody can argue with the fact that if you have feedback about your own patients in a way that's stratified to try and adjust for those sort of baseline factors, then you can look at it. Now, among myself and Dr. Morash and Dr. Kajianos, we have some of that, right? Because we collect that detail, so we're able to do that amongst ourselves, but that service isn't as available to, somebody who would be operating in Cornwall or Perth or Smiths Falls or Beaufort. So I think surgeons would want it. I think it would help them because it would identify ways that we can get better. All right.
Any other questions there from the group?
I've been asked to thank Dr. Breau for coming here for the second time and speaking to us. My experience with him goes back quite a ways. When he first came to Ottawa from the Mayo Clinic, I was in the process of my PSA was going this direction. I had had a radical prostatectomy. I had had salvage radiation, 37 treatments. My PSA was still rising, and I was lucky enough to meet this gentleman, and he agreed to do a second surgery on me. And he did that, performed that, and I'm still here. And I can only say that when I see his chart up here tonight, where his team has a rating of 95% excellency, it's a credit to this doctor, because he's one of the best doctors I've ever had. Bedside manners, the team, I even recognize some of the names on the chart. And I would just like to personally say thank you, and also thank you for coming here tonight again and giving us this excellent presentation. So thank you very much.
Thank you all.
Thank you.